Good afternoon. I'm Brent Roussin, Manitoba's Chief Provincial Public Health Officer. As of 9:30 a.m. today, 177 new cases of the virus have been identified since last Friday. This includes 48 cases on July 3rd, 64 cases on July 4th, and 65 cases today. The current 5-day test positivity rate is 6.3% provincially and 6.1% in Winnipeg. As of last Friday, we have 4 additional deaths related to COVID-19, so I'd like to extend my condolences to their family and friends and loved ones. Today I'd like to continue our discussion about a post-pandemic Manitoba. We know that all pandemics end, and this one will be no different. And so looking at other jurisdictions that have had high vaccine rates, we can see that perhaps this pandemic's days are numbered. Certainly reason to be hopeful considering Manitoba's vaccine uptake. We know that in a post-pandemic Manitoba, our healthcare system won't be strained by a single agent. A post-pandemic Manitoba will not report daily on case counts and test positivity and hospital admissions. And most importantly, a post-pandemic Manitoba will be a Manitoba without public health restrictions. And so with each passing day, more and more Manitobans are getting vaccinated. Nearly 1.5 million doses have been administered in Manitoba already, and this is really a tribute to the vaccine team and to Manitobans for stepping up and getting that vaccine as soon as they can. We need Manitobans to continue to do so as we want to move to that post-pandemic Manitoba. Our ability to reopen businesses, services, facilities, to gather with each other once again, and it relies on Manitobans getting those 2 vaccines. Immunization is our key to a post-pandemic Manitoba. So I urge everyone to get vaccinated with both doses as soon as they become eligible. If we continue to do so, I'm quite confident we're going to continue our reopening plans. We still have a strain on our healthcare system. Numbers are falling and moving in the right direction, but we still see that strain. We're keeping a close eye on a number of those factors, the test positivity, hospital admissions, keeping track of that Delta variant as well. New models right now are being worked on, including that Delta variant, and these mathematical models are complex. They take some time to administer, so we'll be reporting on that shortly. Once that is ready. I'm pleased to introduce Dr. Marcia Anderson joining us today. And so Dr. Anderson and her team have been showing a tremendous leadership role during this pandemic and at all times outside the pandemic as well, and really examining the effects of COVID-19 on BIPOC communities in Manitoba, and really bringing to light those disparities that we've seen in both of our large waves. So I'm going to turn over to Dr. Anderson to provide us some further updates. Dr. Anderson.
Thank you, Dr. Roussin. Hamatakia pe pate dutamanamakia chante washte na pe chuzape nandoe bine signadishnikas. I'm pleased to join Dr. Roussin today and present on COVID-19 experiences for diverse BIPOC communities, including some new severe outcome data. So if we could go to the next slide, please. So between March 31st and June 7th, over 18,808 individual cases occurred, and in almost 77% of those, individuals were asked and had their answer recorded about their racial, ethnic, or Indigenous identity. A small percentage of people declined to answer that question. In Wave 3, compared to the data we presented up until December 31st, a few notable differences. The proportion of cases amongst people who identify as white has gone down, while the proportion of cases amongst people who identify as South Asian, Southeast Asian, or other has increased. Next slide, please. This slide demonstrates that amongst diverse BIPOC communities, the rates of COVID are highly variable. Chinese people are the only population group that are actually underrepresented amongst COVID-19 numbers, although we know they have experienced other negative COVID impacts, particularly related to the rise in anti-Asian hate. However, amongst other BIPOC communities, age-standardized rates are as much as 21 times higher than amongst white communities. When we look at the diverse rates amongst diverse BIPOC communities, we might consider that these could be due to differences in housing status, income status, occupational risks, underlying chronic disease rates, or other different experiences. Next slide, please. As noted on the first slide, 8.5% of Manitobans with COVID identify as an other ethnicity. They are able to further identify themselves in a way that fits for them. And the most common response are people who identify as having more than one race, ethnic, or Indigenous identity. And then the second most common one would be people who identify as Middle Eastern or a related category. Next slide, please. In each population group, except for North American Indigenous, most cases occur within the Winnipeg Regional Health Authority. For North American Indigenous peoples, there were also significant cases in the Northern Health region as well as Prairie Mountain Health, with fewer in Southern Health and Interlake Eastern. Amongst people who identify as white, most cases occurred in the WRHA and in Southern Health Santé Sud. We do know that some health districts in Southern Health have the lowest vaccine coverage rates in the province. Next slide, please. In most racial or ethnic groups, cases are fairly evenly distributed amongst genders. However, in South Asian and Southeast Asian communities, there are more cases amongst males than females. This is likely related to occupational-related exposures and risks, including higher representation in industries such as transportation or manufacturing. Among North American Indigenous people, women experience a higher proportion of cases. This also could be related to occupational risks or potentially to caregiving exposures, such as taking care of children or elders who are unwell and thus being exposed. Next slide, please. Most cases are acquired through close contact with a known case or through community spread. Next slide, please. As this slide shows, the vast majority of cases are now recovered. Next slide, please. One note I will make around this, while I mentioned that of the over 18,000 cases, over 76% had been asked their racial, ethnic, or Indigenous identity, I will note that the lowest proportion of cases who were asked were registered First Nations people living on reserve. So as we consider the numbers for North American Indigenous groups or comparing all BIPOC groups to white people combined, it's important to know that there is a significant undercount that would shift these proportions even further because First Nations on reserve were largely excluded from these counts. This was more to do with how case investigation information was collected as opposed to any other reason. What this graph shows is that the gap in cases between all BIPOC communities combined and cases who identified as white has grown since December. The effects of this on diverse BIPOC communities included stress and grief for community members who were in isolation, in hospital, or who were experiencing fatal outcomes. This also further delayed access to vaccination as a higher number of people were either in isolation as a case or as a close contact, which delayed when they would have been able to schedule an appointment. Next slide, please. Across most age groups in BIPOC communities are overrepresented amongst COVID-19 cases. The only age groups in which this is not true are in the oldest age groups. This is likely related to differential life expectancies, which mean that there are actually lower numbers of BIPOC adults in those oldest age groups. Next slide, please. This timeline highlights some key dates to be aware of as we begin to compare severe outcomes for people who identify as white or as belonging to one of the diverse BIPOC communities. Some members of BIPOC communities have felt stigmatized by messages that people in hospital did something wrong by not following orders, not getting tested, or not getting vaccinated. Moving forward, public health officials will be looking at key policy or program changes, as well as vaccine accessibility, both to ensure the accuracy of the messaging, as well as to continue our focus on public health approaches. So some key highlights of the timeline. On March 20th, the 18-plus First Nations on reserve rollout started. That took place over 4 to 6 weeks in a prioritization sequenced format amongst the 63 communities. March 31st is the initial date we've used for Wave 3 data. April 12th, 60-plus eligible. April 21st, 50-plus eligible. April 23rd was when the neighborhood-based prioritization approach started, which increased vaccine eligibility for neighborhoods that were lower income, that had higher rates of overcrowded or inadequate housing, and that had higher proportions of BIPOC individuals living in them. April 26th is when the urban Indigenous vaccine clinics started to open. May 3rd was when all Indigenous peoples aged 18 and up were eligible. That was also the date that language services was added to the booking line and to the super sites. On May 5th is when people aged 45 and up were eligible. May 11th, paid leave for vaccine appointments was initiated. May 19th is when we saw the peak of Wave 3. The 26th is when we released the first set of updated REI data. On June 3rd, community outreach grants were announced. And since then, we've seen more pop-up clinics, as well as this week, mobile clinics to neighborhoods where coverage is lower. Next slide, please. So this slide is comparing all hospitalizations amongst people who identified as white and people who identified as belonging to a BIPOC community. Based on population size alone, about twice as many hospitalizations than expected would have occurred in people from BIPOC communities, and the hospitalization rate is 3.5 times higher than it was for people who identified as white. In addition, the mean or average age of BIPOC folks admitted to the hospital was 14 years younger. This means that the average person from a BIPOC community was admitted to hospital 23 days, the average person from a BIPOC community admitted to hospital wasn't eligible for the vaccine until 23 days later than the average white person admitted to the hospital. Next slide, please. This slide looks at ICU admissions only. What we can see here is the rate of ICU admissions was over 4 times higher for BIPOC peoples than it was for white people, and the average age was 10 years younger. Next slide, please. So when we look at the epi curve of admissions to ICU, we can compare when people who were that mean age were eligible for the vaccine and how that's different between white people and BIPOC people. We've also added a number there, or a marker there, for the earliest date we would expect them to have any protection, which is 14 days later than when that dose was given. Of course, we also know that most people did not get an appointment for the vaccine the same day that they were eligible for it, but that there was likely at least a week delay in when they could get that appointment. The last point I'll just make as we see the difference in these graphics is that other accessibility challenges such as language barriers or other systemic barriers in healthcare may have led to a greater delay in when the vaccine was actually accessible for BIPOC individuals. Next slide, please. This slide looks at non-ICU admissions to hospital. And again, what we see is that the rate of admission to the hospital for BIPOC folks was 3.33 times greater than it was for white people. In addition, BIPOC folks were 15 years younger than white people at the time of admission. Next slide, please. So when we compare the dates of vaccine eligibility by mean age, what we can see here is actually for white people, a majority of those hospitalizations could have been prevented if people were able to get vaccinated on the same day that they were eligible. However, for BIPOC folks, if we take a look at that graph, what we see is that that earliest possible date of protection occurs after most hospitalizations have occurred. Thus, a minority would have been prevented if people had been able to get vaccinated on that same date they were eligible. Next slide, please. Recognizing that eligibility is not enough for people who already face systemic barriers in accessing healthcare, this chart compares vaccine eligibility and accessibility timeline with that timeline of non-ICU hospitalizations for BIPOC individuals. We'll note that most initiatives to increase access along the timeline, as well as, the pop-up clinics and the ongoing mobile outreach I referred to earlier, occurred too late to significantly reduce the experience of severe outcomes in BIPOC communities during Wave 3. Next slide. This graph is showing the differences in age-standardized ICU admission rates, hospitalization rates, and case rates among diverse BIPOC communities. As with the case rate variations, we also see significant severe outcome rate differences. In addition to factors such as housing and occupational risk, as I mentioned previously, differences in underlying chronic disease rates, as well as access to healthcare, may also contribute to the differences that we see here. Next slide. There are complex interactions between race and income, and they're not independent variables. Racism has affected income through the opportunity or lack thereof to build intergenerational wealth, as well as through access to or barriers to education and employment. While more cases admitted to the ICU are concentrated in the lowest income quintiles for both white people and BIPOC peoples, the risk is greatest in the lowest income quintile for racialized individuals. Next slide, please. This same pattern is seen in non-ICU admissions, where again that risk concentrates most greatly for low-income racialized individuals. Next slide, please. This is acquisition setting data that was previously released. We'll note that lower income racialized people are most likely to live in overcrowded and or inadequate housing, which is the most common acquisition setting household. The data here would lead us to infer that this is a significant contribution to the higher risk being experienced by BIPOC individuals. The second most common acquisition setting was the workplace. Earlier data we released, which included data up till December 31st, showed that BIPOC individuals were more likely to be employed in higher risk occupational settings, which included food processing and food services, manufacturing, the service industry, and transportation. Next slide, please. The presence of underlying chronic diseases has been associated with higher risk of severe outcomes due to COVID-19. However, what this data is showing is that the differences that we're seeing in severe outcomes in the third wave amongst BIPOC individuals are not actually due to differences in chronic conditions. In fact, a significantly higher proportion of BIPOC peoples had no known underlying condition at the time of admission to both hospital and ICU. This would imply that BIPOC peoples experiencing severe outcomes were both younger and healthier than white people experiencing severe outcomes. It would not be possible to tell from our current data what proportion of BIPOC peoples had undiagnosed chronic conditions due to inequities in access to healthcare. Next slide, please. There are no significant differences in the proportion of cases due to VOCs or non-VOCs. Next slide, please. As we consider this data, and I was able to walk through it, contextualize it, analyze it, respond to it with the guidance of the REI Working Advisory Group who's been working with me, we wanted to highlight these key takeaway messages. A reliance on age-based vaccinations likely contributed to the 10-plus year differences in the mean ages of hospitalization between white and BIPOC peoples. In the future, we might want to consider other contextual factors that increase the risk, the intensity, and the frequency of exposures. Low income status compounds risk for BIPOC peoples. BIPOC peoples are less likely to have a known underlying chronic condition, especially for non-ICU hospitalizations. We are unable currently to accurately quantify vaccine coverage for diverse BIPOC communities, and we would need to input the REI data from the consent forms in order to analyze and respond to that information. Next slide. Vaccination efforts and resources should continue to be concentrated in areas where coverage is the lowest, with appropriate community partnerships and appropriate clinical, operational, and logistic support. Although equitable vaccine access should be prioritized, vaccination alone is not sufficient to address gaps in health that are rooted in structural causes, including employment or housing-related factors. Our fourth wave planning needs to prioritize public health interventions that address structural barriers to minimize this disproportionate impact of COVID-19 on BIPOC peoples. We'll now take questions.
Thank you, Doctor. A reminder to our reporters on the line, you will have one preliminary and one follow-up question. Up first this afternoon from CBC Manitoba, Bart.
Hi there, Dr. Anderson. Forgive me because there was no tech briefing on this, so we're trying to digest this pretty quickly here. But can you just explain further the conclusion here that the age-based eligibility contributed to the 10-year gap here between BIPOC COVID patients and effectively white COVID patients? Can you explain that logic and the rationale here to make sure that I understand that?
Sure, thank you for that question. So the way that I would consider it is that when the vaccine rollout started in PCHs, we certainly saw decreased severe outcomes and admissions from PCHs. But when it started in an age-based rollout without consideration of race and ethnicity, aside from First Nations people, what that meant was we were assuming that a 60-year-old African or South Asian person had the same risk as a 60-year-old white person. However, underlying population-level contextual factors, including lower income levels, higher rates of overcrowded and inadequate housing, different levels of occupational risk, actually likely meant that the 60-year-old person from a South Asian or African community was actually at much higher risk than the 60-year-old white person. And when the mean age is, let's say, 15 years different, as it was when we were looking at some severe outcomes, we could interpret that to mean that the risk was the same for the 45-year-old South Asian or African or Black person compared to the 60-year-old white person. However, that 45-year-old person couldn't get the vaccine for about 3 weeks later, which meant they had 3 weeks more of ongoing higher risk exposure.
Okay, I think I understand. Thanks. Now, there was late in the game geographic-based rollout here where some of these ethnic groups that are at higher risk were located. Seeing as you already have some of this data earlier, I guess the question is, why didn't that happen earlier?
Yeah, well, I think when we were, looking at the vaccine rollout early on, one of the most limiting factors was supply of the vaccine. So we tried that, interventions at first. The, most dramatic risk factor was age. And that was how things were rolled out at first. As we saw more and more risk factors, as we got more and more vaccine in, and then we were able to do some more of those targeted interventions. Why it didn't happen, a couple weeks earlier. It's all part of the planning of a complex vaccine rollout. I think we, like any time we implement these things, we learn lessons from it.
From the Canadian Press, Steve.
Oh, hi, Dr. Anderson. I'm wondering if you could tell us what system you would advocate to address the inequities that we've seen, either for the next round of shots, the fourth wave, or even the next pandemic, a decade or two or three from now, whenever that might happen. Would you like to see sort of similar age differentials given to all BIPOC people that were given to First Nations this time?
Yeah, so I think when we're looking for the longer term solutions, that's where we do have opportunities to invest in housing, in educational and employment opportunities to promote that more equal playing field or equal opportunity to be healthy. And then in the shorter term, perhaps even as we're discussing prioritization for booster doses or timing or intervals for booster doses, we could look at this data and say for sure there is an element that's age, that's congregate setting like a PCH, but also we're going to take into account race and ethnicity in terms of how we've demonstrated this higher risk, which can be housing related or occupational related. And I think one way to do that would be to apply those same age differentials.
And Dr. Roussin, we've surpassed a bit of a milestone today. According to the latest provincial data, we've hit and just slightly surpassed the 50% mark for people age 12 and up who've received 2 doses. We're knocking on that 75%. We're very close to it now for that 1-dose rate for people age 12 and up. Obviously, this is well ahead of sort of the target of August long weekend. Is this more than what you expected? And do you see this trend continuing until we hit 80 or 85%?
So it's definitely ahead of schedule of our targets. I think that, it's again a tribute to the vaccine task force, all the people contributing to the vaccine, to Manitobans who have stepped up. So I think it's just, it's quite hopeful to see how quickly we're able to come close to these targets. And given the the dates that we had set forth, we're looking at continuing to be ahead of schedule. So we still want Manitobans to continue to get vaccinated as soon as possible. We still want to get those vaccines out to those that have been unable to get vaccinated for whatever reason. But yeah, we are ahead of schedule. So I think things are looking quite hopeful for Manitoba summer.
From CTV News, Michelle.
Hello, Dr. Anderson. Can you just elaborate a little bit more on what other factors should be considered instead of age or along with age the next time we need this kind of mass vaccination going forward or booster shot?
Yeah, thank you. As I mentioned, I think housing is an important one, and I think we can look at the parallels between different factors that lead to overcrowded or inadequate housing, such as room occupancy, as some of what increased risk in PCH is as well, right? So a higher number of people in a smaller space is going to lead to higher transmission of respiratory viruses, including coronavirus. It would be ideal to be able to do that at the individual level, but that would be incredibly complex to manage. So sometimes that's why we look at these other proxy factors and look more at a population level, such as amongst BIPOC folks who are more likely to live in overcrowded housing as that kind of easier or simpler to implement proxy measure. I think we need to take some serious consideration into how we mitigate the risk that is attributed to being lower income. Some of that is going to be related to housing as well. But as we see, that risk concentrates most greatly for BIPOC peoples. Occupational factors, there are other workplace measures as well that could be taken into effect, and Dr. Roussin's been leading conversations and the public health team has been discussing that as well. But we might also think about occupational risks and how that has contributed to the higher risk we've seen amongst BIPOC individuals. So those are some of the factors that we would consider.
Okay, thank you. Dr. Roussin, any idea on when the modeling that includes the Delta variant will be available?
Yeah, I can't comment specifically on that. I know the efforts have been underway, but we don't have a final product. So, I think it's likely in the upcoming weeks, but I don't have a specific day to comment on right now.
From CHVN, Taylor.
Hi, good afternoon. Dr. Anderson, can you just explain a little bit more about the connection between income and health? Might be a bit difficult for some to understand when we do have free health care in Manitoba.
Sure. So there's a few ways to look at this, or a few factors I would consider. It is true that we don't pay directly for our health care, when you show up to a doctor or a hospital. But there are many reports in what's sometimes called the social determinants of health that demonstrate that actually only about 25-30% of our health status is related to the health care that we receive. A roughly equal part is related to biology, and the rest is to this broad category that we call social determinants of health. And income is a key driver for that. When it comes even to COVID-19, when we think about income, we might think about what occupations would have permitted us to work from home, and then what types of home, Wi-Fi access, etc., we would have needed in that home in order to really protect ourselves from more frequent or more intense exposures to COVID, right? And so we can think a lot about the types of work and what their levels of pay are that contribute to being able to work from home, as opposed to services like transportation, retail, manufacturing, food service that always had to continue to be in person and also are on average lower paying jobs. Right? So that is one way, is what do we get exposed to and how does that relate to our occupation and our income related to that? We can also think about how income impacts what type of house we can afford to live in. And we've talked a lot about housing already today. But obviously people with lower income are going to have less options in terms of buying houses with more bedrooms or more bathrooms that would make it easier for people to self-isolate when it comes to COVID. Financial stress in and of itself, like any kind of stress, can be negative on our health. Our income also facilitates our access to recreation activities, exercise, gym, yoga, fitness, being able to get away from it all and go to the lake, the type of transportation that we can access, as well as our educational opportunities, whether that's the private versus public school decision for elementary or secondary school, or whether it's the universities we can access for post-secondary. So income really does shape much of the access to other factors that contribute to our well-being.
Thanks. And Dr. Roussin, we were talking about the invisible patient a little while back. When is the province going to go back to these non-COVID healthcare procedures and surgeries?
Yeah, so over time, as our case counts have come down, the healthcare system has been able to, change its priorities. So, specifics of that will have to be addressed to shared health. But I think there's been work, continually to try to ensure the healthcare system is there for all Manitoba. And certainly during the peak of this third wave, we saw tremendous strain, and we know that there are significant backlogs right now that will need to be addressed.
Thanks.
From the Winnipeg Free Press, Katie.
Good afternoon. Dr. Anderson, the report concludes that public health needs to address the structural barriers to minimize the impact of the fourth wave. So apart from the recommendations that you made to make long-term investments in housing and things like education, what work is public health doing now to make sure that those kinds of disparities are considered in fourth wave planning?
I'm going to defer that question to Dr. Roussin, actually.
Yeah, and so within public health, there's a number of things that have been implemented and are going to continue to be implemented. One of such is the more targeted vaccine strategy, trying to increase access. Right, we know that eligibility isn't sufficient for much of our population. We need to ensure we're bringing the vaccine to harder to reach populations, so we'll continue to do this. We know certain employment and workplace factors have played a significant role, so we've continued to work on trying to address those factors in that targeted approach. We have alternate isolation accommodations. Again, the attempting to address or offset some of those issues with the difficulty of isolating in certain areas. We know that we need to ensure we can make those more welcoming, more available to places that have crowding. So there's a number of factors that public health is directly working on, and then there's the broader factors that Dr. Anderson also commented on.
Okay, and I have another question for you, Dr. Roussin. We've seen mask mandates being lifted in other areas, other provinces. Is Manitoba considering lifting indoor mask requirements?
Well, like I said, we are trending towards a post-pandemic Manitoba. So we are heading to a place where we're going to have public health recommendations, but not restrictions. So we're going to be trending to an area like that. We'll have recommendations, about where to, indoor public places around people where you're not sure of their vaccine status. We're probably going to continue to recommend people wear masks. Right now, we are just in the downtrend of a very severe wave 3 here in Manitoba. So right now, we still require these restrictions. But over time, that is the goal, is to move to public health recommendations rather than restrictions.
From Global News, Anya.
Good afternoon to you both. We just went through some extreme heat, and I'm sure there will be another time during the summer we'll experience temperatures similar. Is there any guidance from public health on mask wearing in these extreme temperatures, whether that means taking it off if you feel yourself overheating, even if that is indoors, as a lot of people don't have air conditioning?
Yeah, so I think that we've always had exemptions to mask wearing and related to underlying health conditions, and so heat wouldn't be any different. Our mask requirements are in indoor public places, and so many of those do have the opportunity to be air conditioned while at home. There isn't a mask requirement. So it really depends on the circumstances. Certainly the immediate health is important. There's many things to, safeguard against heat exhaustion. You can find that, online on our web pages. We've opened up a number of sites, ensure that there's cooling centers available and the splash pads, etc. So wearing a mask indoor public place, still a requirement with some exceptions, but places that say at home there isn't that requirement.
Okay, thank you. And we know kids under 12 are unable to get the vaccine, and yet they're still allowed to travel and go to a restaurant as long as everyone they're with is vaccinated. Obviously, it makes it easier for families. But can you talk to us about the rate of transmission from children, and if there's not still a risk that children could carry and spread the virus, even though many others are vaccinated, especially once schools open?
Yeah, and so the issue there is we had to, make decisions because, 12 and under just aren't eligible right now. We think that will change at some point, but we don't have a specific time. So we need to make rules that accommodate that. The other thing is we do know from studies that the risk of infection in that age group for severe outcomes is much less than the adult population, and even the risk of transmission is lower in that age group. So we do base it on that level of risk, but keeping in mind that we're never risk-free. We see we accept the risk in so many aspects of our life, and in this post-pandemic Manitoba that we are traveling towards, it's not going to be a post-COVID Manitoba. And so like many other health factors, we need to decide on how much risk we're willing to take as individuals, how much of the public health recommendations at that point that will apply to us and that we want to follow. But right now, given the vaccine rate that we're having, given those other contextual factors with those under 12, we think it's appropriate to have that exemption for those under 12 if they're with vaccinated adults.
From the Brandon Sun, Kimberly.
Good afternoon. This question is for Dr. Roussin. Dr. Roussin, I'm just wondering, is there any progress that's been made on the immunization cards for international students who currently can't get the card because they don't have a Manitoba health card?
Well, there is work being undertaken right now. I don't have any specifics to share or an exact date on when we can announce anything, but there will be something upcoming. There's work being done right now.
Okay, thank you. This question is for Dr. Anderson. Dr. Anderson, I'm curious, how effective was the language services for the BIPOC community that when they made a phone call, they had access to their own language? Can you comment on that?
We don't actually, at this point to my knowledge, have any evaluation metrics on that as yet. I will note that with the increasing pop-up clinics that are in locations such as cultural centers that are known to community, that there's also much more opportunity for that interpretation in those types of services as well. So I think there's ongoing work, but I can't speak to the evaluation of it as yet.
From CJOB, Skylar.
Good afternoon, doctors. Thanks for your time. Just wondering, is there any indication that children under 12, in whatever age groups, whether it's 7 to 12, 10 to 12, or anything otherwise, will be able to get a COVID-19 vaccine before they head back to school? I know that's something a lot of parents are concerned about.
Yeah, so I know there are some trials ongoing right now evaluating the effectiveness of children under 12. So they'll need to be completed, and then companies will need to submit to regulators. So as far as a time frame, I don't think that we'll be seeing that prior to going to school, but it will, it all depends on the results of studies, how quick they can be done, and how quick the submissions can be reviewed. So there's work being done, but hard to know when we'll be able to move on that.
Okay, thank you. Obviously, our numbers continue to look encouraging and go in the right direction. I also know that, given we were last of the third wave, a lot of us saw things happening in other jurisdictions, and eventually saw it happen here later on. And now we've seen in jurisdictions like the UK, there's been an uptick in hospitalization rates, although the vaccine campaign is continuing. It seems to be stalling. Obviously, that's something that you pay attention to. But are there any fundamental differences between a place like the UK where they are starting to see a slight uptick and are putting the brakes on things versus Manitoba that could help provide some context so people aren't as concerned?
Well, I mean, I think we need to certainly be aware of the issues in other jurisdictions. We see in some where there's seeing that increasing transmission of the Delta variant, seeing it in vaccinated individuals. In many jurisdictions are not seeing that translated into the severe outcomes, the hospitalizations and increases in ICU. We've increased our vaccine uptake quite rapidly, and we're reaching targets that are exceeding many jurisdictions in a very quick manner. So I do think that being double vaccinated, being fully vaccinated, is going to protect somewhat against that Delta variant, and certainly quite a bit against severe outcomes related to any of the variants. So, I think the trajectory of our vaccine uptake is what's going to make a difference for us as we move forward. But we need to be aware that virus is still circulating. We still see the virus here. We still see severe outcomes. We still announced 4 deaths over the weekend here. So we're still going to be dealing with this virus. We're going to be dealing with this virus throughout summer, and then we're going to be dealing with respiratory virus season this fall, which will likely include COVID, influenza, and RSV. So we need to pay attention to these public health guidelines. We need to be vaccinated as soon as possible. But looking at our numbers, looking at our vaccine rates, I think we're still on that trajectory to a post-pandemic Manitoba where we're going to move from public health orders to public health recommendations.
From the Winnipeg Sun, Scott.
Hi, good afternoon to both of you. I guess first question for Dr. Anderson. The First Nations rollout was done differently on age basis. I remember it was maybe 10 years difference in between each drop for ages. Is there a reason why that wasn't also then transferred or used in the same way for other BIPOC communities?
You know, I do not sit at the level of vaccine task force tables. I know that part of the reason we were able to successfully advocate for that age differential for First Nations people was because of the regular, transparent, and availability of data that we had. We didn't always have the same data for different BIPOC communities as well. I know the idea had been raised at different times. The neighborhood prioritization sequence was a response to try to start to include some elements of that, where we were starting to see some differences in coverage by community area as well. But I can't speak further to the deliberations that happened at the vaccine task force around that.
All right, thank you for that. Second question, I guess, for Dr. Roussin. In Dr. Anderson's slides there, it said that some BIPOC communities felt stigmatized by the blaming messaging that happened early on. Was that a failure by public health to kind of cast a shadow on people who were, hadn't gotten vaccinated yet or weren't seeking out testing? Because the message on the slide seems to suggest that kept people away from those things.
Yeah, and so I think that there's a difficult balance there between risk communication, and then stigma. And so we saw some of the early REI reports, which has really given us this data to act on. Even then, the release of those, there was some negative comments from certain communities feeling that was stigmatizing. And so it certainly wasn't the intent to stigmatize. It's about risk communication, epidemiology, but there is that risk. So when we speak about the vaccine and how effective the vaccine is, that we do not see our ICUs filling up with vaccinated people. You risk coming across as blaming, but it really is risk communication, trying to show the benefit of vaccine, trying to show the benefit of of the protection it provides. So there is that balance that's there.
Our final reporter this afternoon from CBC Radio Canada, Charles.
Hi. Question to Dr. Anderson. To Black, Indigenous, and other people of color, what would you suggest them to do right away to protect themselves against COVID-19?
So I certainly agree with Dr. Roussin that if people could get fully vaccinated as soon as possible, that offers one of the strongest measures of protection that we can. And then I would encourage you to share your vaccine story, how you got about making that choice, what the experience was like, where you went for it, what sources of information you looked at that you trusted. Share that with others in your family and in your community. Maybe we can be part of helping to ensure that coverage is as high as everywhere, or as the highest parts of the province as well. So I think certainly getting vaccinated is incredibly important. And then otherwise would continue to follow the public health fundamentals, as we've said all along. And the last thing I would say is really to embrace the time over the summer that we have to reform connections, to do the things that we love, safely, of course, to connect with our communities, our cultures, the land, and to try to recover from the intense times of racial stress that we've all experienced over the past 15 months or so.
Thank you very much. And question for Dr. Roussin. Do you think the Delta variant will be a concern for kids when returning to schools?
Well, it's certainly a concern for everyone, right? We see this, any virus here, the COVID virus that's being transmitted. We see if it's transmitted significantly anywhere, that's going to eventually be transmitted everywhere. And so I think that we have to be aware of this variant. We have to be aware of all the variants. And so the best way to protect those that can't be vaccinated is for all other people to be vaccinated. So we have very high uptakes of vaccine throughout the population. We're actually going to stretch that protection to those that are unable to be vaccinated. So I think we still are on that path to that post-pandemic Manitoba that we're talking about. We know how important in-class learning is for schools, and we're really going to do whatever we can to continue to make that safe, but to have our kids in school.
Thanks, everyone. This concludes our media briefing.